Welcome to today's presentation on the ventilation of on pulmonary ventilation. So by definition, ventilation is just the exchange of air in and out of the body. In other words, you can say it is a breathing in and a breathing out of air. Now, this movement of air is driven by a lot of factors, which include the pressure gradient that exists between the environment and the lungs, and the elastic properties of the lungs, as well as the elastic properties of the thoracic cage, as well as the compliancy of the lungs. So all these factors, they culminate together to enable the body to carry out ventilation, which is very important because it is this process or mechanism of ventilation that allows air to come in, to bring in the oxygen that is needed, and also help the body to expel out the carbon dioxide that is not required and needed. Yeah. The lungs can be expanded in two main ways. They can be expanded and contracted. So the space inside can be increased and reduced in two main ways. The first way is by downward and upward movement of the diaphragm to lengthen or shorten the chest cavity. That's the first method by which lungs can be expanded and contracted. It is by the upward movement of the diaphragm, which makes it or which lengthens it or shortens it. The chest cavity also is increased or decreased in the very manner. Then the other means is by elevation and depression of what? The ribs, to either increase or decrease what? To increase or decrease the anteroposterior diameter of the chest cavity. We'll explain how this occurs. Yeah, so this is what we are talking about, that during inspiration we see that this diaphragm is contracted and pushes down there. As you can see, this arrow shows that the diaphragm is going down as this process occurs, as inspiration occurs, and the ribs are elevating, going up like that. They are going up like that. So this increases, first of all, this vertical diameter, the depression or the flattening of the diameter as the diaphragm pushes downwards. It flattens and increases this vertical distance. Then at the same time, these ribs are moving up and out, up and out. This increases this anterior posterior diameter. That is the diameter that they're increasing. So the ribs are increasing this diameter. That is the anterior posterior diameter. Then the diaphragm increases this diameter. That is what it does. This occurs during inspiration. Why does this occur? It's because it is trying to create enough space for the air that is coming in to be accommodated. That is why these mechanisms are very important. Then during expiration, it is the opposite that happens. This distance needs to be reduced, as you can see that it has reduced here. Why does it reduce? Because now you want to expel out the air that your area accumulated. Now to expel it, the diaphragm pushes up. So when it pushes up, it forces the air to move out. It forces the air to come out like that, because the diaphragm is pushing up like that. So this is because it is relaxing and then it is curving upwards. It is curving upwards. So curving upwards, meaning it is reducing the space, the vertical distance. At the same time, the ribs are coming down and pushing a bit inside. So this also reduces this distance, the anterior posterior diameter. So it also kind of squeezes the air out of the body. So these are the mechanisms, or these are the different ways on how the lungs are expanded and relaxed or contracted together with the thoracic cavity. So these movements are very necessary to allow air to come in and also leave the body. So in other words, these movements or mechanisms are important for ventilation to occur. Yeah, so during inspiration, what contracts? The diaphragm. So as the diaphragm pulls the lower surfaces of the lungs downwards, then during expiration, the diaphragm simply relaxes, and the elastic recoil of the lungs, the chest wall, and the abdominal structures, they compress the lungs and expels the air. That is just what I'm just explaining. Yeah. When during heavy breathing, now this is different. This is mainly during quiet breathing. Normal breathing, when one is relaxed, seated, this is what happens. Now, during heavy breathing, the elastic forces are not powerful enough to cause the necessary rapid expiration. So they are not enough to cause the rapid expiration. So extra force is achieved mainly by what? Contraction of the abdominal structures. That pushes the abdominal contents upwards against the bottom of the diaphragm, thereby compressing the lungs. This leads us to what we normally refer to as what? Diaphragmatic breathing. Diaphragmatic breathing. So during heavy breathing, you need more than just the elastic recoil of the lungs to cause expiration. There is need now to forcefully expire the air that has accumulated. So this is what diaphragmatic breathing is. So you can see that you can see the two diagrams here. On this side, as you can see there, this is the lung, and this is the diaphragm. Then this is the abdomen. Now, there are structures here, there are muscles and other abdominal structures here on the abdomen. During inhalation, the belly is out like that, the diaphragm is just in its normal state as well as then during exhalation, you can see that the belly has pushed in. Now, pushing in of the belly, what has it done? It has increased this space inside, so meaning it has pushed the contents up. As these abdominal contents are going up, they are also pushing on the diaphragm, which assists it in doing what? In pushing, reducing this thoracic cavity space. As this reduces, it pushes the air out. It helps it in exhaling. So this is what we call diaphragmatic breathing, where the abdominal contents help in expiration by pushing against the diaphragm to help it expel out the air. That is diaphragmatic breathing. And then that was the first way. It was via the expansion of the diaphragm, the contraction or relaxation of the diaphragm. That was the first way. The second way by which the lungs are expanded and contracted, it is by way of raising the rib cage. So when you raise the rib cage, the volume or the space inside the chest cavity increases, and including also the volume of the lungs, it increases. So the rib cage expands the lungs because in the natural position the ribs are slanted downwards. Yeah, so when the rib cage is elevated, the ribs are projecting forward, and also the sternum tends to push also forward, increasing the anterior posterior diameter of the chest, and this increases by about 20% during maximum inspiration than during expiration. That is, the anteroposterior diameter increases by that much if the ribs as well as the sternum are pushed upwards and outwards. They increase the what? The anteroposterior diameter. So during inspiration, this is what we normally see. So you can see that these arrows are for the diaphragm, which is coming down as this person is inspiring. The diaphragm is coming downwards. Then we can also see that we have the rib cage there. These ribs are coming outwards like that, expanding. So they are moving out, outwards and upwards. So this increase of the rib cage increases the anteroposterior diameter, which allows for the accommodation of air inside the chest cavity. Then during expiration, it is the opposite that happens. You can see that the rib cage is drawing inwards. So the ribs are drawing inwards like that as the chest contracts. So this is the same thing here. You can see that you have these ribs that are coming outwards and somewhat moving upwards. Outwards, upwards, outwards, upwards. At the same time, you also have the sternum that is doing the same, like that, like that, like that, this side. Then this is during inhalation as the chest contracts, but during exhalation, it is the opposite. These are coming down now. They're coming down and inwards, down and inwards, down and inwards. That is how this contracts. Now, the most important muscles that raise the rib cage are the external intercostal muscles. Of course, there are others that do what help it, but the major muscle that plays, the major muscles that play an important function in raising the rib cage are the external intercostal muscles. Others, which are referred to as muscle, as accessory muscles of respiration, we have the sternocleidomastoid, which lifts up on the sternum. So the sternocleido lifts the rib cage from the sternum. Then we also have the anterior serrati, which lifts many ribs, and also the scalene, which lifts the first two ribs. So when these muscles are contracting, they pull on the rib cage and it lifts up and goes out. That is, yeah. So you can see that this looks like the one of the bellies or the heads of the sternocleidomastoid that comes to insert on the sternum there. Then we have also the scalene muscles that are coming to insert on the first two ribs, that is this rib 1 and rib 2 there. Then we also have the others now, the external intercostal muscle. As you can see, the arrangement is in such a way that the external intercostal muscles are arranged in such a way that they originate from the inferior border of, the superior border of the inferior rib and insert on the inferior border of the superior rib. That is where these muscles are inserting. They are coming from the lower rib going to the upper rib, such that when the muscle contracts, and remember that as a rule of thumb, we say that a muscle, when contracted, it moves it moves towards the point of insertion. So when it contracts, it pulls from the inferior rib going up. That is why you are saying when you are during inhalation, as the external intercostal muscles are contracting, they pull on the inferior ribs. So this will be pulled up. So this will be pulled up. 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 And by that, you find that this whole rib cage is done what? Is pulled up like that. Even this side. Because every inferior rib is pulled up by these muscles, and coupled with that, you have the other accessory muscles that are lifting and pulling on the sternum to go up also. So as this contraction is happening, this ribcage is doing what is expanding because of the activity and action of these muscles. The opposite is true for the internal intercostal muscles. The insertion is opposite, meaning they are inserting from the superior rib going to the inferior rib. That is the internal intercostal muscles, from the superior to the inferior, such that when they contract, they are pulling the ribcage downwards and inward. So it's downward and inwards. At the same time, these muscles are relaxing. The accessory muscles will be relaxing to allow that to occur. Yeah. So that is the mechanism that leads to the expansion and contraction of the chest cavity. Yeah, so the muscles that pull the ribcage downwards during expiration are mainly the abdominal recti and the internal intercostal muscles. So the abdominal recti muscles, those have powerful effect of pulling downwards on the lower ribs, at the same time that they and other abdominal muscles also compress the abdominal contents upwards against the diaphragm. So the abdominal muscles are doing two things there. So as they are pulling on the lower ribs to reduce the rib cage, the space or the volume inside the rib cage, they are also compressing on the contents of the abdomen to push against the diaphragm so that you can expel out the air. And during expiration, they are angled downwards, and the external intercostals are elongated forward and downwards as they contract. So this is what I was explaining. So as the external intercostal muscles contract, they pull the upper ribs forward in relation to the lower ribs, which causes the leverage on the ribs to raise them upwards, thereby causing inspiration. And the internal intercostals function exactly in the opposite manner, functioning as expiratory, because they angle between the ribs in the opposite direction and cause opposite leverage. Yeah, so this is what I was just talking about. When they contract, these ones are lifting these ribs down, pulling them up like that. So when this muscle contracts, it pulls it up. When this muscle contracts, it pulls this guy down. Yeah, so contraction of this pulls this rib up, then contraction of this pulls this rib down, so that this side you can expand, so that this side you can expand the rib cage, and this side you can contract the rib cage. Yeah, that is the arrangement of the intercostal muscles. Yeah, this is also just the same thing. Now, when those events occur, what changes are seen? One, the thoracic cavity changes that occur are that the anterior posterior diameter does what? Increases because of what? Sternum elevation, of course, as well as the elevation of the ribs. So there's an increase in the anterior posterior diameter. Then there's also transverse diameter that increases due to rib rotation. Okay. Then there's also vertical diameter that increases via the diaphragmatic descent. Yeah. So the diaphragmatic difference, that's what increases. Then there's also thoracic volume. The thoracic volume increases approximately to 500 mils during tidal breathing. So this increase is just to accommodate the tidal volume that we breathe in during normal quite inspiration. That is it. So these are some of the changes that are seen as the thoracic cavity increases. Yeah, so this is just a summary now of the events that occur during inspiration. So inspiratory muscles contract, that is the diaphragm, descends and the rib cage rises. This increases the thoracic cavity volume, which stretches the lungs. Intrapulmonary volume increases. Intrapulmonary pressure drops to at least less than -1 millimeters of mercury, and air or the gases flow into the lungs down from its pressure gradient until intrapulmonary pressure is 0, equal to the atmospheric pressure. So these are the events that happen, and the opposite happens in expiration. So in expiration, of the inspiratory muscles that are relaxing now, that is the diaphragm rises, the ribcage descends due to recoil of the costal cartilages, then the thoracic cavity volume decreases, elastic lungs recoil passively, intrapulmonary pressure decreases, and intrapulmonary pressure rises to positive 1 millimeters of mercury, and this forces the air to come out. That is these are some of the changes that are noticed that I'm explaining. So ribs elevated and sternum flares as external intercostals contract. The diaphragm also moves inferiorly during what? Contraction. So this also expands the chest cavity. The external intercostals are contracting. Then the opposite also does what? Occurs, where the ribs and the sternum are depressing and the diaphragm is relaxing, reducing the volume inside the chest cavity. The external intercostal muscles are also relaxing at the same time, meaning the internal intercostals are what? Contracting. That is what is noticed. Now, we have discussed the mechanics of ventilation. Now we move on to look at the gases and their pressures in the atmosphere, in the chest cavity, and also as that atmosphere. The first law that we're going to look at is Boyle's law. And by definition is that for Boyle's law, we're saying when pressure is varied against volume, the relationship is an inverse one, provided all other factors are kept constant. And in this case, we're talking about temperature being kept constant. So when pressure is kept constant, when temperature is kept constant, pressure varies inversely as the volume, meaning that when pressure increases, volume does what? Decreases. That's what it means. It means that when pressure increases, volume decreases. That's what this statement means. Or when pressure decreases, volume increases. That's what this statement means. It means the pressure and volume are varying inversely. It also means that the initial pressure times the initial volume should be equal to the final pressure times the final volume. This relationship makes an assumption that temperature is kept constant. So when temperature is constant, this equation is used to compare different conditions of the same solution. Yeah. So pressure is inversely related to the volume, and the pressure multiplied by volume equals to the constant K. So this is the Boyle's law. The other law is the law of Laplace. So this one is for the alveoli. So let us look at these two alveoli. There's alveoli B and alveoli A. When you look at these two, the difference is mainly in terms of the size, and in this case, the radius. So this one has got the radius 1, and the radius of alveoli. The radius of alveolus 1 is, alveolus A is 1. The radius of alveolus B is 2. Now, when you look at the law of Laplace, which states that pressure is equals to 2 times the tension over the radius. 2 times the tension over the radius. It therefore means that when you substitute in this equation, assuming that the pressure is 50 millimeters of mercury, the tension is 50, it's 50, assuming that the tension is 50, you discover that when you substitute there, so 2 times 50 over the radius, which is 2, gives us a pressure of 50 millimeters of mercury. Then the alveoli there, when you substitute, you have 2 times 50, but the radius there instead of 2 is 1. That is, it gives us 100. It therefore means that according to the law of Laplace, the pressure is equal to 2 times the tension over the radius. So this one compares to, in this case we're using the alveoli. So it therefore means that the difference is mainly in the radius. If a given substance has got a reduced, a bigger radius, its pressure will reduce. A smaller radius increases the pressure inside the surface. So if it's in the alveoli, if an alveoli has got a reduced radius, it is going to have a lot of pressure there, as compared to an alveoli that has got an increased radius. So this is important, especially when we talk about surface tension. The surface tension, because the forces that are trying to collapse lungs, what is helping, or what is also at play in that case is this law. Is this law. So what is also at play. Now, what are some of the important definitions that we should at least remember also, as we've already introduced this? Elasticity. So elasticity is just the tendency of the lungs to do what? To recoil. That is elasticity. The tendency of the lungs to do what? To recoil. And compliance is simply the extent of expansion of the lungs for every increase in transpleural pressure. So that's the amount of, it's just the ability of the lungs to increase as pressure increases. You increase in volume and capacity as the pressure of air and the pressure increases. That is what compliance is. Now, there are 3 pulmonary pressures that are of great importance that we're going to look at. There's what we call the alveolar pressure, the intrapleural pressure, and the atmospheric pressure. So all these are the 3 important pulmonary pressures that we discuss. So as you can see, intrapleural pressure is just the pressure within the lung parenchyma there, within the lungs, and it is approximately equal to 760 millimeters of mercury. So the intraalveolar pressure, so IA, is equal to approximately 760. That is the intraalveolar pressure. Then there's also what we call intrapleural pressure. So if you see, if you look at the lung here, the lung is covered by a layer of a membrane there. This membrane is called the pleural membrane, and the one that is attached to the lung parenchyma is the visceral pleura. The one that is attached to the rib cage is the parietal pleura. In between these 2 membranes is a potential space that we call the pleural space, and in this space there's a little amount of fluid that functions to just cause lubrication, so that the 2 membranes, as they are sliding against each other, because they are tethered together, so they do not do what they do not injure each other because of friction. So there's a little bit of fluid to cause lubrication. So within this space there's pressure that exists there. So the pressure of the pleural space is called the intrapleural pressure. So intrapleural pressure is equals to what? It is slightly less than the intraalveolar pressure, and it is about 756. So in other texts you find that it is written as -4 millimeters. In other texts the intraalveolar pressure is about 0 millimeters of mercury. So these pressures are written in relation to the what? Atmospheric pressure. So atmospheric pressure is equal to what? 760. That is what atmospheric pressure is. It is about 760. So it is in relation to the atmospheric pressure. So why is this 0? Because in relation to the atmospheric pressure, so you're going to say intra-alveolar pressure minus intra-alveolar pressure minus atmospheric pressure, which is 760 minus 760 gives us 0 millimeters of mercury. Then for the intrapleural pressure, you're going to say 756 minus 760 gives you negative 4. So these are measured relative to the atmospheric pressure. That is these pressures within the alveoli and the pleural space. And the difference between the intra-alveolar pressure and the intrapleural pressure is what we call the transpulmonary pressure, which is about 760 minus in fact it is 756 minus 7 plus 760, sorry, but it is the difference between these two pressures. So this difference between these two pressures is known as the transpulmonary pressure, so which is positive 4 millimeters of mercury. Now if you notice, this intrapleural pressure is what? Negative. The intrapleural pressure is negative, and there are about 4 factors that contribute to making this intrapleural pressure negative. That's what we're going to also look at. So I think this has already been discussed, as during inhalation, the diaphragm contracts and moves downwards or intercostal and expands the thoracic pressure below the atmospheric pressure, causing a drop in pressure which allows air to flow into the lungs to equalize the pressure. Yeah, so this is just the same thing that we're from explaining. So now remember that we are saying the atmospheric pressure and the intrapleural pressure are the same. Now these are the two that communicate. It therefore means that if air is to either move in or out, then one of the pressures must just go below or above the other. One should just go below the other so that there is a pressure gradient that is created. Now during inspiration, as those events are happening where you have the diaphragm relaxing during inspiration, you have the diaphragm contracting, the rib cage also doing what? Contracting. It raises the volume inside the cavity. Raising the volume inside the cavity meaning decreases the pressure. According to Boyle's law, the pressure does what? Decrease. So this is the thing, So intraalveolar pressure, so as the diaphragm relaxes, as the diaphragm contracts, meaning it becomes flat, and the rib cage increases, it elevates and expands. This increases the volume inside, and according to Boyle's law, when this volume increases inside, the pressure does what? Decreases. So if the pressure decreases, it means the atmospheric pressure is now more than intra-alveolar pressure. And as long as it just falls to at least even negative 1 millimeters of mercury, then air is going to flow in. So it creates a pressure gradient. And as air begins to flow in, the volume begins to do what? The volume of air begins to increase. So as the volume begins to increase, there's too much air now. So as the air has accumulated, the mechanics of now expiration kick in, where you have the diaphragm now relaxing, meaning it is now coming up, the rib cage is also coming down. This tries to reduce the volume of the chest cavity. Reducing the volume of the chest cavity does what? Increases the pressure within the chest cavity. So as the pressure within the chest cavity increases, meaning the pressure within it now goes to slightly above 0, meaning positive 1 millimeters of mercury. Once it just reaches positive 1 millimeters of mercury, the direction of air now changes from the chest cavity inside to outside, because remember that the atmospheric pressure is zero according to what we are from discussing. So it's okay, you can either say it is 760 or it is equal to 0. So once it goes just above the 760 mark or the 0 mark, the pressure inside the chest cavity, air is going to flow out, and this is what drives expiration, the pressure gradient. So it is the pressure gradient of air that drives out the movement of air from either the environment into the lungs and also from the lungs into the environment. Just the pressure gradients that change. Yeah. Yeah, so we're saying during exhalation, the diaphragm and the intercostal muscles relax. This reduces the thoracic cavity volume. This decrease in volume increases the intrapulmonary pressure above the atmospheric pressure, which causes what? Air to flow out of the lungs. And thus, Boyle's law is very fundamental to the mechanics of what? Ventilation, as it enables the pressure changes that drive the inflow and outflow of air. Very important law. Then alveolar pressure is the pressure of air within the alveoli. So it is equal to the atmospheric pressure and is approximately 760 millimeters of mercury or 0 millimeters of mercury. So this pressure must fall slightly to a value less than what? 0 millimeters of mercury to draw air inside the lungs. So a drop to -1 millimeters draws about 0.5 liters of air into the lungs. And this process occurs in what? 2 seconds. That's when. So this, in other words, we're describing inspiration. And the opposite must happen for what? Expiration to occur. So the increase to about +1 millimeters of mercury expels about an equal amount of air that had been drawn in, about 0.5 liters. And this process occurs in about 2 to 3 seconds. Then we also have pleural pressure. So this we said is the pressure in the pleural cavity. Yeah, it is the pressure in the pleural cavity. So this pressure within the pleural cavity is called the intrapleural pressure. Now we said this pressure is approximately -4 millimeters of mercury. Now what is it that makes this pressure negative? So the first one is because of what? Remember that this is the pleural space and that fluid is continuously produced. The pleural fluid is continuously produced. So because it is continuously produced, it must also be removed continuously. The pressure must also be removed continuously. So if this pressure is going to be removed continuously, then there should be a suction force. And in this case, what creates that suction force there is the lymphatic drainage. So there are lymphatic vessels that are connected to the pleural space. So it is this lymphatic drainage that creates a suction pressure. Because it is continuous, it creates a suction pressure that sucks out the fluid from the pleural cavity. So suctioning out of this pleural fluid creates a negative pressure that draws out the fluid. That is also one of the factors that contributes to the negative pressure inside the cavity, the pleural space. Yes, that's number one. Number two, why this pressure is negative is because of the elastic recoil of the chest wall. So now remember that when you look at the chest cavity, the thoracic cage, the rib cage, when we say elastic recoil, its elastic recoil is outwards. It wants to recoil going outwards. But now remember that it is the wall of the thoracic cage is covered by what? The parietal pleura. So meaning if the rib cage is trying to expand outwards like this, it is also pulling on the what? The parietal pleura. So if it is trying to pull on the parietal pleura, it is trying to increase the space, the pleural cavity space. It is attempting to increase the pleural cavity space. So if it is attempting to increase the pleural cavity space, it means that the volume there is doing what? Is increasing. So if the volume is increasing, what is happening to the pressure? The pressure is decreasing, hence contributing to this negative pressure. So the elastic recoil of the chest cavity contributes to this negative pressure. Why? Because its elastic recoil is outwards. So as it pushes outwards, it pulls also on the parietal pleura. So as it pulls on the parietal pleura, the space within the pleural cavity increases. There's an attempt to increase the pleural cavity space. So this pleural cavity space, as it increases, it increases the volume. And according to Boyle's law, when there's an increase in volume, the pressure must come down. That is why it has to go less than 760 millimeters of mercury, and hence contributing to the negative pressure. Number three, the other factor is the elastic recoil of what? The lungs. The elastic recoil of the lungs. The lungs are trying to pull where? Inside, like that. The lungs are trying to pull on the inside, like that. But remember that the lungs are tethered to what? The visceral pleura. So as they try to recoil inside, they are pulling also on the what? The visceral pleura. So as they are pulling on the visceral pleura, just like the thoracic cage, it is also attempting to increase the volume of the pleural cavity. Meaning, if the volume is going to be increased, the pressure must also come down, hence contributing to the negative pressure. So we've talked about how many things? We've talked about the suctioning pressure of the lymphatic vessels, the elastic recoil of the chest, as well as the elastic recoil of the lungs. The final component or factor that contributes to this negative pressure is surface tension. The surface tension. Now, remember that surface tension is just a force that attempts to collapse the alveoli. The surface tension is the force that tries to collapse the alveoli. So now it tries to. So if assume this is your alveoli. Surface tension is just a force that tries to pull this alveoli inside so that it collapses. So if it is trying to pull the alveoli inside, meaning it is trying to reduce the alveolar space. Now remember that this lung is almost entirely made out of these alveolar sacs. So meaning that if there's an attempt to reduce or to collapse the lung, meaning it is attempting to decrease the what? It is attempting to pull this lung inside. It is attempting to pull this lung inside. Now what is happening as it is attempting to pull this lung inside? It is trying to draw it away from the pleural space. Now remember that there's a visceral pleura again here. So as the surface tension is trying to pull the alveoli inside to collapse them, it is attempting to increase the pleural cavity space. Again, increasing the pleural cavity volume decreases the pleural pressure. So because of that, you have what? You have a negative intrapleural pressure. You have the negative intrapleural pressure. So 4 factors that we have discussed that contribute to the negative pressures, the negativity of the intrapleural pressure. Number 1, the suctioning force of the lymphatic drainage. 2, the elastic recoil of the chest wall. 3, the elastic recoil of the lungs. And 4, the surface tension within the alveoli. These are the factors that make or contribute to the negativity of the intrapleural pressure. Then we said there's also transpulmonary pressure, which is just the pressure difference between the alveolar pressure and the pleural pressure. So it is a measure of the elastic forces in the lungs that tends to do what? To collapse the lungs at each instant of a respiration, called the recoil pressure. That is the transpulmonary pressure. It's just the difference between the alveolar pressure and the pleural pressure. That is the transpulmonary pressure. Of course, this is just also trying to explain the same thing from explaining. So this is this here is the intrapulmonary pressure, the transpulmonary pressure, and the one below here is the intrapleural pressure. So during inspiration, you can see that the intrapulmonary pressure, which is the same intraalveolar pressure, has gone below 0 there. So when it goes below 0, it draws in air. At the same time, the intrapleural pressure increases its negativity. Then at maximum inspiration there, about to transition to expiration, the pressure starts doing what? Going up like that. So all the pressures are trying to go up like that. So during inspiration, all the three pressures must slightly reduce. Must also slightly reduce to draw in air, and must also increase to draw out air. So the pressure difference between the intrapulmonary as well as the intraalveolar pressure is what we call the transpulmonary pressure. Yeah, then we also talked about lung compliance. So lung compliance is a measure of what? The elastic properties of the lung. Lung compliance is the measure of the elastic properties of the lung. It reflects how easily the lung is distended. It measures how easily the lungs can be distended. And lung compliance is defined as the change in volume resulting from 1 centimeter of water change in the distending pressure. That is what compliance is. Change in volume over pressure. Yeah, and then the units of compliance are what? Milliliters per centimeter of water. So when lung compliance is high, the lung is readily distended. When lung compliance is low, the lung is what? Stiff. The lung is not easily distended. So the compliance of lung is expressed as what? Yeah, so the compliance of lungs or lung compliance is given by the formula. Compliance is equals to change in volume over the change in pressure. So now this change is what? The transpulmonary pressure. The difference between alveolar and the intraalveolar and intrapleural pressure. That is what this change in pressure is. So this is what determines the compliance. So when the lungs can easily be distended, it means the compliance is what? High. But then if the lungs are stiff for some reason, it could be due to conditions or whatever reasons, then the compliance will be low. It will be difficult for us to expand the lungs. Now, compliance is simply a characteristic of several or other factors, mainly determined by what? Elastic forces of the lungs. And these forces can be the elastic forces of the lung tissue and the elastic forces caused by surface tension of the fluid that lines the inside walls of the alveoli and the lung air spaces. So two main determinants of lung compliance: elastic forces as well as the surface tension. These are the main determinants. So the elastic forces are determined by what? The collagen fibers as well as the elastin fibers. The collagen fibers as well as the collagen fibers and the elastic fibers are the ones that determine the elastic properties of lungs in as far as compliance is concerned. So the elastic forces from surface tension are much more greater. Yeah, so surface tension plays a much even bigger role. So surface tension is simply a force caused by water molecules at the air-liquid interface that tends to minimize what? The surface area. So which makes inflating the lungs more difficult. Like I had mentioned, so you assume this is your alveoli. Surface tension is simply the force that tries to draw in this alveoli. And it is because of the cohesive forces of the fluid at this interface that tries to pull these fluids, these molecules of liquids together. So as they are trying to stick together, they are also pulling on the surface of this alveoli, trying to draw it in. So the higher this pressure is, the more difficult it is going to be to inflate these lungs, because they will try as much to collapse this alveoli. Now what helps to reduce this tension is the surfactant. That is what helps to reduce this tension. Surfactant, which is simply a compound made up of lipids, proteins, and other chemical compounds, and with a major component being dipalmitol-phosphatidylcholine. Dipalmitol-phosphatidylcholine is the major component of what? Surfactant, which tries to reduce the surface tension so that this lung does not collapse. So the surfactant comes to break in some of these forces. So when some of these forces are broken down, it means that surface tension goes down. So it reduces the amount of the force that is trying to collapse this. Meaning, in that instance, now it becomes easy for us to inflate and expand this lung, because the surface tension has done what? Reduced, because of the surfactant that was present. So now pulmonary surfactant is synthesized by alveolar type 2 cells stored in the cell in lamella bodies and are secreted into the alveolar space. So it is predominantly lipid, and the most dominant lipid is what? Dipalmitol-phosphatidylcholine is the dominant lipid that is present there. Yeah, so this is just what I'm explaining. So the surface tension, you can see that there's too much pressure there. So you can see that you have pressure, but this pressure is not enough compared to the surface tension. So the alveolar pressure is these black arrows. They're just forward. When you look at the surface tension, there's too much surface tension, almost double the alveolar pressure. Almost double the alveolar pressure. So it will be difficult for this pressure to expand this lung, because the tension that draws this inside is too much. So what surfactant comes to do is it comes to eliminate some of the, or part of this tension that is created. Yeah, and this is just an experiment. So when the lungs are filled with air, there's an interface between the alveolar fluid and the air in the alveoli. Now, in the case of saline solution fluid lungs, there is no air fluid interface. The surface tension effect is not present, and only tissue elastic forces are what? Operative in solution. That is why you can see that there's no, this difference does not exist when you fill in these lungs with the saline. Yeah, so that marks the end of this presentation. It's a long one, but thank you very much. Thank you very much for staying this long. Please remember to like, to comment on this video, and also share it, invite others, subscribe to this YouTube channel, so that every time we post any new video, you are able to get notified. Cheers.